moving on to our next topic, I'm pleased to introduce to you someone I've met a long time ago. For our classmates here who joined us in our HTTP or HIV telehealth training program for the 5 iterations, I owe it all to Todd, no? Because without their model in Vietnam, wala tayong pagkakopya. So it was a model which we actually applied here in the Philippines. It's wildly successful, and we're looking for more opportunities to have more batches to join our HIV telehealth training program. So now, wearing a different hat to talk about community advisory boards and experience from Vietnam, I introduce to you Dr. Todd Pollack, the country director for the Partnership for Health Advancement in Vietnam, or HIVN. Hi, Todd.
For the introduction, and good to be here with all of you, more than 90 participants. Thanks, Kate and the other organizers for inviting me. Experience with what we call the community advisory boards in Vietnam, which were developed as part of the S&D-QI work that we implemented in Vietnam. You could kind of say that HIVN is sort of implementing organizations similar to SHIP, and we were helping the local departments of health of different provinces in Vietnam to do stigma reduction and to do the S&D-QI model. And as part of that, we created a mechanism for communities. Sorry, the S&D reduction approach. And so what I want to share with you today is that experience about how we created this mechanism and what the community advisory boards do. Well recognized now, and I'm sure everyone here would agree with me, that engaging and empowering people and communities is one of the key strategies to creating a strong health system that is people-centered.
Hey, Todd, you're going in and out. I don't know if it's your mic or what. Can everybody else hear? I can't hear Todd. Can anybody else hear him?
I'm going to switch to my other microphone. Is that better?
Yes, that's better.
That's better?
Yeah, you may want to go back one slide.
Oh, I'm sorry. Okay. Too bad. Okay, so what I was saying was that it's well recognized that one of the key strategies to the creation of a strong health system is having mechanisms to engage and empower people and communities in health system delivery. But what do we mean by engaging and empowering people and communities? And so I'd like to show on this slide a very nice framework developed in this paper by Carmen et al. That shows us that when we talk about patient or community engagement, we're really talking about a continuum of engagement. And so there's different levels we can look at. And if you look at the top, you can see from consultation to involvement to maybe the highest level of engagement, partnership, and shared leadership. And I think we can look at the middle boxes, the red and orange boxes, that is, I think, applicable to what we're talking about here in terms of S&D-QI approaches, where we have one level of engagement is under consultation that we organize, and that the organization, like your clinic, surveys patients about their care experiences. But a higher level of engagement would be involvement, where the facility involves patients as advisors or advisory council members. And then even higher level of engagement there, and here we might consider it empowerment, is where the patients or communities co-lead efforts to improve quality and safety in the hospital. So I think this is a nice framework to help us think about what we mean when we use kind of buzzwords like community or patient engagement. The same paper also gave us an even simpler framework, where we're starting with maybe thinking about patient and community engagement as complaining, and going across this different levels. Ultimately, we want to get to experience-based co-design of health services. So how are we doing in terms of getting our users of our HIV services, whether those living with HIV or those at risk of HIV, in being engaged and empowered in our health services? Well, it's hard to measure that, I think, but I pulled out this one question from the PLHIV Stigma Index implemented in Vietnam in 2020. And perhaps you had this same question in your Stigma Index study that you implemented in the Philippines, where it asks what proportion of those surveyed said that they were involved with activism, advocacy, or resilience strategies within the last year. And the results showed that very few, actually, only 4% reported that they were participating in any kind of effort to reduce or address stigma and discrimination. And so when we were implementing the QI-S&D program, we were thinking, why is that? And one of the reasons we were thinking is that there wasn't really a formal mechanism that allowed patients or community members or clients to have that opportunity to engage. So we looked around the world to try to find examples of mechanisms, formal mechanisms, like clearly defined mechanisms that would enable that. And so we found a model from New York State, which Bruce had been involved with, and where they had, I think they called it a consumer advisory board at the time. Bruce can correct me later. And this was basically a mechanism for service users and community members to provide meaningful inputs and advice into the development of policies and programs that address their needs. And so using the New York State model as an example, we created what we call the Community Advisory Board in one province in Vietnam. And the way we did it was we really advocated, from our position as the implementing partner to the Department of Health of this province, that creating this kind of mechanism that would allow the community members to have their voices heard was beneficial, that it was a win-win situation for the health staff and the service providers who really needed input from the service users in order to develop effective strategies to address the issues that were raised, like quality issues or stigma, and also a way to kind of advertise or introduce the services that they were providing at the clinics to those who would need them. And then from the clients and the KP community side, it was a win for them because they really wanted to provide, they wanted to really have that opportunity to provide their input and to, feel like they were being valued and appreciated and, working to help improve quality of services for themselves and for their community. So we established this community advisory board. Now I'm going to tell you how we did it. Oh, thanks, Bruce. I'm just checking the chat here. So what was the purpose of the Community Advisory Board? Well, at the beginning, it was really simply to have this engagement of people living with HIV and KP communities in the discussions about quality of care, about stigma, of course, and other quality gaps. And we also wanted the Community Advisory Board to be sort of a bridge between the health system and the other service users, so they could help advocate for raising up community voices in the health programming and quality improvement initiatives. So really at the beginning, it was really just trying to create a mechanism to have regular opportunities for community members to have their voices heard when thinking about service quality. But as the program went on, then we had sort of higher goals, which was, to move further along that continuum of engagement, to have our CAB members be part of the quality improvement teams in the facilities and to help co-design and to jointly implement the interventions that were being designed. And lastly, the CAB members had sort of a responsibility to inform and educate the broader community about the different health services that were going on, as well as to get the word out about the improvement plans, because the facilities, the health system, they were working hard to address the gaps found in their quality, in the quality of the program, or the gaps found in the SNDQI surveys. And, it was important for those efforts to be recognized by the broader community. And the CAB was another mechanism to educate the community about what was going on at the facilities. So just some nuts and bolts about the model. So it's largely a volunteer effort. So community members are nominated either by the facilities or by community-based organizations or leaders of the KP community. And we try to kind of make the Community Advisory Board reflect the community that they were representing in terms of age, in terms of demographics like age, gender, membership in different key populations. Now, of course, although we called it a volunteer program to be on the Community Advisory Board, we did provide members with small stipends for different activities that they might participate in, and also transportation support. So since we had a project, we did have some funds to provide small stipends, but largely we designed it as a volunteer program to try to help it be more sustainable over time. One of the keys to the success, at least in the Vietnam context, was that we institutionalized the model within the public health sector. And what I mean by that was that the Community Advisory Board for each province was recognized by the Department of Health of that province. So they issued paperwork, like a local paperwork, like a decision to establish this Community Advisory Board. And within that, we had standard operating procedures and terms of references for how the CAB would operate within the province, what the roles and responsibilities were of the CAB, what the governance of the CAB was, but also what the roles and responsibilities were of the health system in terms of engaging with the CAB. And then in case you're thinking about setting up your own Community Advisory Board Community Advisory Board mechanism, I just shared this slide here, which was kind of a step-by-step on how we went about doing it, at least in the Vietnam context. So the first step was we had a consensus meeting where we introduced this was after we had established the first CAB model that I talked about in the first province. But then when we were scaling it up, we would have a consensus meeting with the Department of Health and other key stakeholders where we would introduce the CAB model and the approach, and we would get the Department of Health, if they agreed, to issue kind of a a preliminary approval to move forward with starting the model. And then we would do recruitment by sending out a letter to all the health facilities and through other channels to invite people to apply. And then a group, including the Department of Health and our project team, would review the applications and interview potential members. And then the members were selected. And then step 3, there was an orientation to the CAB members in terms of the function of the CAB. And then the CAB would elect their own co-chairs. Then capacity building is a big part of this, providing information to the CAB members, the basics of HIV and HIV services that are available at the provinces or the site that they're supporting, communications skills, and quality improvement basics. And then we had a launching where we would finalize the terms of reference and standard operating procedures for how the CAB would operate. And the Department of Health issued a formal decision that established the CAB, as I showed on the previous slide. And then there was the implementation, which we'll talk about, and then ultimately scale up. So how did the CAB, what kind of activities did the CAB members get involved in S&D-QI? So the CAB members were key members in doing data collection for the patient survey, the client survey. At the beginning, we did face-to-face interviews. So the CAB members were trained and they were the ones who would do the data collection. Later, when we moved to digital collection, CAB members were still on site to help clients who might have some digital literacy problems to still be able to do the survey. CAB members also participated in S&D reduction training, sharing their experiences, giving testimonials, etc. And as I mentioned, they were sort of part of the quality improvement teams at each facility, helping to interpret the data from the S&D-QI surveys and helping to come up with solutions and interventions to address the gaps and helping to implement the QI projects at the facilities, which I'll show examples of. And then over time, we developed another activity called the community dialogue. This was an opportunity to get the input, hear the voices of people not engaged in care, because the S&D-QI surveys were getting the input, getting the information from those in care, but not those not in care. So the CAB started facilitating sort of community meetings, basically, to hear from members of the broader community about their concerns. So, but really the key work that the CABs helped make successful was to encourage the service users to provide feedback. So either through participation in the S&D-QI survey process, or to give less formal ways of feedback, either through a comment box or there was a telephone hotline set up. So encourage the feedback to be provided, collect that feedback, summarize that information, and then the CABs were able to discuss this feedback and well as solutions and improvement ideas with the facility staff and with the Department of Health staff in kind of workshop formats as part of the quality improvement team of those facilities, as I mentioned. And over time, the model started to look something like this, where we had, sorry?
Go ahead, Todd.
Okay, we had different means of collecting feedback from the community, either through the surveys, hotline comment box, the community dialogue I mentioned, and that the CAB was sort of facilitating the collection of all those different mechanisms. And then we would have what we called the CAB meeting, where that data would be presented, and the Department of Health or the Provincial Centers for Disease Control would present the different initiatives going on at the health facilities, and the CAB members would present the initiatives they were involved in, and there would be discussion about the quality of services and what could be done at the health facilities and what could be done at the community to help improve quality or reduce stigma. And there's some concrete examples of what this kind of discussion between the health system and the community led to, as I listed on this slide. Some of these came directly from QI surveys and QI data, but some of these came from informal feedback. For example, the first one, that people's names were being called over loudspeakers at the clinics when it was sort of their turn for care, or when they were needed at registration, and to ensure confidentiality. Patients didn't like that, and they encouraged a different system, and the CABs came up with this system of calling an ID number, and that was adopted at the health facility. The CABs also advocated for longer consultation hours to reduce wait time. They also helped to spread the word to communities when there were new services available at the clinic. So when hepatitis C treatment became available for people living with HIV, it was the CABs that were sort of doing the outreach to the communities that that they had networks with, to inform them of that new service. And then in terms of viral load results, so I think you also have in your tool a section on health literacy. So we also focused a lot on health literacy, especially understanding one's HIV viral load results. And the CABs were really important in successfully helping to increase the percent of people who knew their viral load results, but both by helping to advise on the kind of language that should be used that would be most understandable for patients, and then also to actually helping to implement the QI project by providing information to clients in the waiting room and doing sort of random checks of people's knowledge to see whether the efforts that were being done were working, and if not, making further adjustments to the way the quality improvement project was being implemented. And then, over time, once this model was being implemented for a while, there was really trust between the CAB and the health system. So then the CAB started to be asked to do more and more. And this included, like, one time when there was an ARV shortage and people needed to be moved to another clinic or to have some adjustment made to their ARVs. The health system really went to the CABs to help them to mobilize, to ask them to mobilize to ensure treatment continuity of the patients who were at that clinic with the supply chain problem. So this is the current status in Vietnam. The first CAB was established in 2019. The Vietnam government issued a national guidance on CABs, sort of basically a national SOP on how they operate. And it's currently operating in 6 provinces. And currently, the Vietnam Ministry of Health is planning to expand the model to provinces that have high incidence of HIV. We did a evaluation of the model, and here's some quotes from healthcare workers and CAB members, and it was universally got high marks from all sides in terms of the model. So here's my last slide. some lessons learned. So, I mean, I think first of all, like empowering the community is absolutely necessary to eliminate S&D and improve quality and access. I think all of you would probably agree with me on that, but I think the experience we had in Vietnam is can really speak to that. I personally think that we can't just talk about like we need engagement, we need empowerment of communities. We need to have specific mechanisms that allow for that within the health system, and that's what the CAB did in Vietnam. And perhaps there's different mechanisms in different settings, but that's the one that so far has worked well in our context. Of course, like in any effort, capacity building is very important. Making sure CAB members are oriented, and also that the health workers and the Department of Health, the health system is oriented. And there's training in a variety of topics, including advocacy skills, are very important. Really need to build the trust between the health system and the communities. All of these activities may not be possible on day one, but at least starting that conversation, that dialogue can help build trust. And then over time, as I tried to show in my example, the health system really started to rely on the CABs for different things that they needed to be successful. And of course, open and transparent communication, respect, and trust is so important. Another thing, that I want to mention is we collect all this feedback from the clients. And I think it's really important just in general in this work to have a commitment to at least addressing the major problems that you identify. We don't want to collect all this information from people and then sort of ignore it, or at least give the appearance. That's why we found it so important to have the CAB members go out to the community and tell them, look, your facility is doing something about these problems that were found. So people, feel that their voices are being heard. So that tried to give you an overview, hopefully, since it's 9 p.m. Here and my brain is starting to get sleepy, that it made sense. But happy to have any questions. And here's my acknowledgements for those who helped make this model a success. Thank you very much.